Welcome back to week 2 of our psychology course, Exploring Abnormal Psychology. Last week we examined the historical perspectives informing our current understanding of abnormal behavior, and we discovered that there are multiple ways in which different professionals in the field approach their understanding. We explored perspectives that are based on a biological medical model, a psychological and a behavioral model, as well as a sociocultural model. Finally, we examine two interactionist perspectives that pull on understanding from several of these current models and try to create a more in-depth understanding of abnormal behavior. This week, we will expand on our understanding of these perspectives as we look at assessment, classification, and treatment of abnormal behavior. In Lecture 2A, this first video lecture for this week, we will examine how we assess abnormal behavior and how that is done differently depending on which perspective a professional is coming from. Assessment will look differently in each of these perspectives. In Lecture 2B this week, we will look at classification for abnormal behavior. This section of the lecture will primarily be looking at the DSM-5 Diagnostic Statistics Manual, which is the Diagnostics and Statistics Manual of the American Psychiatric Association, and is the North American Guide to how abnormal behavior is classified or labeled. This will lead us into our third and final part of the lecture this week. In Lecture 2C, we will look at treatment options that are currently available to individuals diagnosed with mental health disorders. Again, you will notice that the treatment options or approaches, as well as the modalities, will vary significantly depending on the perspective from which the professional approaches the challenges exhibited by the client. Today, we tend to see teams of mental health professionals that incorporate the various perspectives and that recognize the value that comes from the interaction of the biological, psychological, and social models, and the wisdom and collaboration in determining best practice and treatment choices for any one individual. So let's get started by examining the way in which mental health professionals from the various perspectives interact with the client to assess the challenges that they are presenting. As with any medical appointment, the clinician needs to understand the problems and challenges the client is coming in with. A careful assessment provides a wealth of information about a client's personality and cognitive functioning or thinking skills. This information forms the foundation of the decisions made later on in the treatment plan for the client. When we talk about methods of assessment, this refers to techniques that a clinical psychologist or clinicians use to achieve a diagnosis. Methods can include such things as interviews, psychological testing, including intelligence, personality tests, and Rorschach or thematic apperception testing, behavioral assessments, cognitive assessments, physiological measures, and brain activity and imaging techniques. We will take a look at each of these types of assessments as we continue on throughout the lecture. Before we proceed, it is important to recognize that there are other factors that also need to be considered. For example, assessment techniques may be reliable and valid in one culture but not in another. Most diagnostic instruments consider culture to some degree, but most fail to provide adequate norms for different cultural and ethnic groups. Interviewers need to be sensitive to problems that can arise when interviews are conducted in a language other than the client's mother tongue. So let's start by taking a look at the clinical interview. The clinical interview is the most widely used means of assessment. It's usually a face-to-face interview between the clinician and the client. The clinician starts the interview with a basic question such as, "What kind of troubles have you been having lately?" From there, the clinician will probe or ask more questions to uncover important aspects of the complaint. During the interview, the clinician will collect information about past episodes, daily functioning, and life events. It is important that the client answers questions in their own words, reflecting on their own experiences. While interviews vary from practitioner to practitioner, They all aim to cover the same topics. Topics typically covered in an interview include identification of the data, so looking for basic socio-demographic information such as the client's marital status, age, gender, religion, employment, etc. Then descriptions of the presenting problems or behaviors. How is the client perceiving the issues? How does it influence the client's daily functioning? And when did this behavior begin? Followed by psychosocial history, looking at the client's developmental history, education, social, occupational history, and early family relationships. And then looking at medical or psychiatric history. Does the client have a history of medical or psychiatric treatments? And finally, medical problems or current medication the client might be using. Discussion of any present medical problems, things the client is being treated for, and current medication that the client is taking. The clinical interview can take one of three basic formats: the unstructured, semi-structured, or structured format. In an unstructured format, there is no standard order for the questions, and the clinician develops his or her own questions as they go. Often the questions are generated in response to what the client is saying in order to provide opportunity for the client to clarify or expand on their responses. This line of questioning may change based on the client responses. The next possibility is the semi-structured interview, in which the clinician does follow a general outline of predetermined questions, but is free to ask the questions in any order or to create probe questions to collect more information. And finally, the most rigid of the interview formats is the structured interview format, in which the clinician follows strictly a preset series of questions in a specific order. The next category of assessment strategies and instruments that we will look at are known as the psychological tests. These tests include structured measures of assessment that are relied upon to evaluate reasonably stable traits such as personality and intelligence. These tests are typically standardized on large numbers of subjects to provide normative scores that client scores then can later be compared to. By comparing test results from a sample population of individuals that do not exhibit the abnormal traits being assessed, clinicians gain insight into the types of response patterns that might indicate normal versus abnormal behavior. In the category of psychological testing, we find intelligence tests and both objective and projective personality tests. We will now proceed to examine samples of each. An assessment of abnormal behavior often includes a measure of intelligence. Intelligence is a controversial concept. It refers to the capacity to understand the world and also to cope with its challenges. From this perspective, we are looking at the way in which a client mentally represents the world and adapts to its daily demands. In the development of an intelligence test, traits that are associated with success in adapting to the demands of the world are represented and measured on this instrument. Intelligence tests allow clinicians to develop a profile of client strengths and weaknesses, to diagnose where there are delays, and develop treatment plans for the client accordingly. The Stanford Binet Intelligence Scale was developed by Alfred Binet and Theodore Simon in 1905 for a French public school seeking to identify students which may benefit from a specialized educational program. The first version of this scale yielded a score called the mental age, or the MA, which represented the child's overall level of functioning. A score of 8 for the MA would mean that the child is functioning as a typical 8-year-old. In 1916, Louis Terman of Stanford University adapted this test for American children. Wechsler defined the average IQ as the child's mental age, or the age at which a child is mentally functioning. times the child's actual or chronological age, or how old the child actually is. This number is then multiplied by 100 to provide an IQ score for the child. This is what we commonly still refer to today as the IQ score. Wechsler determined that the average range for any individual should be between 90 and 100 points. 90 and 110, 15 points. 90 and 110 points, sorry. This is the point where the IQ score of 50% of the population would fall. Anything above 110 indicated an above average level of intelligence, whereas anything below 90 indicated a below average level of intelligence. From the graphic on the screen, we can see that only 5% of individuals will have an IQ score above 130, and only 1% will have an IQ score above 145. On the other side of the bell curve, we see that only 5% of the population will have an IQ score below 70, and only 1% will have an IQ score below 55. This bell curve will be important to keep in mind next week when we look at neurodevelopmental disorders in children, as this scale is still widely used as a diagnostic instrument today. David Wechsler developed various intelligence tests for children, the WCIS, and for adults, the WAIS, based on the methods of this deviation IQ, which means how many points are you above or below 100, which is the average or midpoint where the majority of people will fall. The Wechsler scales are grouped into subtests, verbal and performance subtests, each of which measure different intelligence-related tasks. The Wechsler scales were innovative in that they did not just provide the participants with a numerical score, but they also provided insight into the strengths and weaknesses. The Wechsler IQ scores are based on the participants' timed responses and how that deviates from the scores by age mates and has become the standard for scoring IQ tests today. This slide provides examples of the various subtests found on an adult Wechsler intelligence test. The first category one might see is information, where you might see any question based on general information, like who wrote the Iliad. Comprehension would be a test that looks at your ability to comprehend what something is saying. What does the saying, "the early bird catches the worm," mean? In the arithmetic subtest, you might see a typical calculation problem, such as you want to buy six cupcakes, which cost $8, but you only have $5. How much more money do you need? In the similarities, you'll either receive two words or two images, and you'll be asked, how are these two things alike? For example, how are a pen and a pencil alike? In the digit span, you'll be asked to repeat back a series of numbers, either in the same order or backwards. In the vocabulary test, there will be various words in the English language of varying degrees of difficulty, and looking at how many of them you can find a definition for. And finally, the letter number sequencing subtest, in which you listen to a sequence, for example, F3T6Y9, and then repeat back to me first the numbers from the least to the most, and then the letters in alphabetical order. This slide shows an illustration of items similar to those found on a Wechsler adult intelligence test. In the upper half of the illustration, we see a rectangle with dark and light green shapes. The task would be to decide which of the shapes, from numbers 1 to 6, would fit in the light green colored area of the top rectangle. In the lower half of the illustration, we see two balance scales that demonstrate objects that are of equal weight in this example. The first scale shows that two dark stars equal two light rectangles. This is the example. The second scale asks which objects from numbers 1 to 5 would equal one dark star. Based on that example, the correct answer should be one light rectangle, or box number 3. The Wechsler includes a number of subtests designed to evaluate a client's thinking and problem-solving capacities to determine their IQ score. Cautions to intelligence testing. There are a number of things or factors to consider when we look at the validation of intelligence testing. The first is cultural bias, and these have to do with the questions or the material included in the test, and do they allow for predominant cultures to have an unfair advantage. The next one has to do with learning disabilities. Sometimes learning disabilities are not accounted for. If a client has reading difficulties, for example, they may answer incorrectly because they could not comprehend the question, not because they did not know the answer. And finally, gender differences. Inherently, tests have shown that males outperform females on certain tasks, and females outperform males on others. Is the composition of the test fair for both genders? In addition to testing for intelligence, psychologists also test for personality. There are two different categories of personality testing. Objective personality tests are administered by a professional and measured against a standard, much like intelligence tests. The two main tests used in this category are the MMPI, or Minnesota Multiphasic Personality Inventory, and the PAI, or the Personality Assessment Inventory. The second classification are the projective personality tests and can include the Rorschach inkblot test and the thematic apperception test. Let's take a look at examples of each category and discuss the way in which they're used and the type of useful information they can provide to help the clinician understand and assess the client. In the Minnesota Multiphasic Personality Inventory, it is the most widely used personality test. It uses self-report questions to measure personality traits such as anxiety, depression, emotionality, hypomania, masculinity or femininity, or introversion. These results are compared to a normative sample to reveal the client's standing. It is considered an objective personality test because the range of possible responses is limited. These are self-report measures, and with that come both benefits and disadvantages. The benefits of these self-report measures, such as the MMPI, are the ease and economy of administration. They uncover information often missed in a clinical interview or observational setting as well. The disadvantage is that they rely on the client as the source of data. The test responses may reflect underlying biases on the part of the client. Examiners will often use additional supporting information such as interviews and assessments of family and friends. The MMPI-2 is the second version of the test and is widely used today in diagnosing abnormal behavior patterns. It consists of over 500 true or false statements that reflect interests, habits, family relationships, somatic complaints, attitudes, beliefs, and behaviors. The instrument is comprised of a number of individual scales that tend to be answered differently by members of carefully selected diagnostic groups, such as patients diagnosed with schizophrenia or depression, rather than by members with no abnormal behaviors. The validity of the MMPI is supported by a large body of research, which shows its strength in deciphering control and psychiatric groups. The validity of a test refers to the degree to which the test actually measures the trait or construct it is intended to measure. The MMPI has validity scales that assess tendencies to distort or fake test responses in either a favorable, as in faking good, or unfavorable, faking bad, way. In this way, the test is able to recognize when someone is deliberately trying to fake a disorder or to cover up the existence of a pattern of abnormal behavior. As you can imagine, it can take quite a lot of time to respond to 500 true and false statements. This can lead to other problems such as clients that become disengaged because they are tired of answering questions and then begin to provide random responses. Again, the results of the MMPI are only as reliable as the honesty of the responses provided by the client. Another objective personality test with about equal validity to the MMPI-2, and that can be completed in about half the time, is the Personality Assessment Inventory, or the PAI. This inventory provides significant advantage for clients that find it difficult to sit and concentrate for extended periods of time, such as individuals with a cognitive impairment or those challenged with depression or impulsivity. Objective Personality Test. The PAI is an objective personality test with close links to the Diagnostics and Statistics Manual of Mental Disorders, or the DSM. It provides information relevant for clinical diagnosis, for treatment planning, and for screening of psychopathology. This test consists of 344 Likert scale items and requires about 50 to 60 minutes to complete. A Likert scale item can be responded to on a 4-point scale, including very true, mostly true, somewhat true, or false, not true at all. There are cautions accompanying objective personality tests. Due to the fact that these tests are self-report measures, it works on the premise that clients will answer honestly. There is potential for bias or inaccurate self-perceptions. When clients do not answer truthfully, the test is a false representation. Validity scales are used to try to reduce these faults from occurring, or when they do happen, to help the interpreter to recognize it. Unlike those objective personality tests we just discussed, projective personality tests do not provide clear or specified answers. They are called projective because they work from the premise of a psychodynamic theory. They work from the premise that people project their psychological needs and motives from the unconscious into ambiguous stimuli. One example of a projective personality test would be the Rorschach inkblot test. This test was developed by Hermann Rorschach in 1921. This projective personality test is based on the premise, again, that people will see different things in the same inkblot. Our perception of these blots reflect our personalities. Based on the responses, different inferences are drawn. This slide is an image similar to what a client would see on a card of a Rorschach inkblot test. The inkblot is actually, literally, a drop of ink placed on a piece of paper, and then the paper is folded in half and opened again to create a mirror image of the inkblot on both sides of the page. Another projective test would be the Thematic Apperception Test, or the TAT, created by Henry Murray in 1943. This work works on the basis that we interpret based on our existing ideas and experiences. A series of cards with ambiguous scenes are shown, and the client is asked to form a story based on that scene. It is thought that their stories reflect their experiences and outlook on life. Results also suggest that the responses reflect attitudes towards others, such as family members, lovers, and friends. Some cautions to consider when looking at projective personality tests. These tests are largely based on a clinician's subjective interpretation of test responses, in contrast to empirical or observable evidence. The validity of these tests are also controversial. Attempts have been made to create a systematic scoring grid, but the responses still remain open to individual interpretation. In the TAT, some photos may be too emotional and cause clients to answer based on empathic responses. Another form of testing entirely would be neurological assessments. Neurological assessments are tests designed to detect signs of underlying neurological damage or brain defect. They are used to evaluate whether or not psychological problems are the result of neurological damage or brain defects without surgical intervention. These assessments are often accompanied by brain imaging techniques, which we will explore further in this lecture as well. The combination of neuropsychological assessment and brain imaging techniques helps to uncover whether the brain damage is present and what areas of the brain are involved. If neurological impairment is suspected, a neurological evaluation would be requested by a medical professional, and a neurologist who specializes in disorders of the brain and the nervous system. The Luria, Nebraska test battery is one example of a neuropsychological test. This test is used to reveal patterns of skill deficits that are linked to a particular region of the brain. It represents a wide range of skills that are assessed, including tactile, motor, auditory, receptive, and expressive speech, reading, writing, arithmetic, memory, and intelligence. This test has been shown to be highly consistent, although validity and reliability are still being researched. This test is appropriate for people aged 13 and older and takes between 90 and 150 minutes to complete. Looking at behavioral assessments, this is an approach which is used to objective recording and descriptions of problem behavior rather than making inferences from personality traits. It uses the psychometric approach, which looks to identify and measure the stable traits of personality that determine behavior. Behavioral assessments can include such instruments as an interview, self-monitoring, role-playing, or behavioral rating scales. A behavioral interview focuses on trying to understand a behavior in context of the antecedent stimulus, or the event that took place just before the behavior happened, as well as the reinforcement consequences, in other words, the consequences that result from the behavior. Think back to last week's lecture on positive and negative reinforcement and punishment. In short, a behavioral interview provides information about what may be causing the behavior rather than focusing on the personality of the individual. The interviewer may pose questions to learn more about the history and situations where the problem behavior typically occurs. The textbook provides the following example on page 51. If the client is looking for help because of panic attacks, the behavioral interviewer might ask how the client experiences the panic attacks. For example, when, where, how often, and under what circumstances does the panic attack occur? The interviewer will look for precipitating cues, such as thought patterns. What is the client thinking about just before the panic attack occurs? Or situation factors. Do the panic attacks tend to happen in a similar situation each time? Oftentimes, these assessments are accompanied by objective or projective personality tests as well. Aside from the behavioral interview, there are other forms of behavioral assessment available to the clinician. Self-monitoring is a process in which the clinician trains the client to keep notes or a record of their daily lives to try to create information to help understand the context of a troublesome behavior. Analog or contrived measures are intended to simulate the setting in which a behavior naturally occurs, but are carried out under the supervision of the clinician. This can often include role-playing. And finally, behavioral rating scales are checklists which provide information about the abnormal behavior involving the use of a checklist to record the frequency, intensity, and circumstance of the abnormal behavior. One such checklist is called the CBCL, or Child Behavior Checklist, and is often completed by parents to rate their children on more than 100 specific behavioral problems. The clinician then compares the scores on the checklist to the scores of typical children in the same age range to determine the existence or the extent of a problem behavior. Cognitive assessments involve the measurements of cognitions, in other words, of our thoughts, beliefs, and attitudes. It is believed that individuals can hold self-defeating or dysfunctional thoughts that place them at risk of developing emotional problems, such as anxiety and depression. These assessments help to identify these self-defeating thoughts so that the clinician can work with the client in changing them to positive, rational, and self-enhancing thoughts. One technique used in cognitive assessment is a thought record, which we encountered last week as the work of Beck when he developed CBT, or cognitive behavior therapy. The thought record is a process in which a client is trained to record in a diary or journal the information regarding the situation, what they were thinking, what was negative or irrational, what a more rational or positive response could have been, and what the emotional outcome of the situation was. By later reading through these authentic examples of the negative behavior, the clinician can guide the client into recognizing and changing the behavioral responses as they happen in their real life. Aside from psychological assessments that we've just discussed, there are several assessments that are biologically based, including physiological measures. We utilize people's physical responses in their association to abnormal behavior. Some examples of these include the galvanic skin response, or also called electrodermal response. This test measures the electrical conductivity of the skin. This is increased when we sweat as a result of being anxious or nervous. The electroencephalograph, or EEG, uses electrodes placed on the skull to measure electrical brain activity in waves. We can measure states of relaxation and sleep with an EEG. An electromyograph, or abbreviated EMG, monitors muscle tension through electrodes placed on the muscles. Tension again is reflective of states of anxiety. And finally, ambulatory measures. By monitoring blood pressure at different points throughout the day, we gain insight into feelings of stress. These are often used in conjunction with self-report diaries of feelings. Next, we'll take a look at measures that probe the workings of the brain. Refers to the use of medical technologies to reveal the inner workings of the brain without any invasive technologies or surgeries. There are two types. There are structural versus functional. A structural will actually look at an image of the brain, where a functional will take an image of how the brain is functioning at that particular point in time. We'll review 7 different types of technologies available in brain imaging. You can also refer in your textbook on pages 57 to 58, table 2.4, for detailed outlines of each of these assessments. The first we'll look at is the electroencephalogram, also EEG for short. This records electrical activity of the brain through electrodes placed on the skull. In the image you see on the screen, we have an electrode cap, which is frequently used, but it's also possible to place the electrodes directly onto the skull. An EEG is used to examine brainwave patterns associated with psychological disorders, such as schizophrenia, and with brain damage, as well as with various abnormal behavior patterns. Also used to reveal brain abnormalities, such as brain tumors. This is considered a functional measure as it measures the electrical activity at a particular point in time. The next measure we'll look at is the CT, or computerized tomography. It's a machine that aims a narrow X-ray beam at the head to measure multiple angles. It reveals shapes, structures, lesions, clots, and tumors. So this is a structural measure in that it is looking at the structure of the brain at that point in time. It provides evidence of brain damage that was once detectable only by surgery and may now be displayed on a monitor. The next one we'll look at is positron emission tomography, or the PET scanner, which produces a functional image and shows the biochemical activity of the brain at any given point in time. A safe radioactive dye mixed with glucose is injected into the bloodstream, which makes its way to the brain and reveals regions that are at work. More active regions metabolize more glucose, revealed by the positively charged particles present with the glucose, and represented on the scan by the areas that are most bright. The MRI, or magnetic resonance imaging, is a structural brain image technique that can be used to investigate abnormalities in the brain associated with schizophrenia, and other disorders such as obsessive-compulsive disorder. A person is placed in a donut-shaped tunnel, not unlike what you saw in the photograph for the computerized tomography. And this tunnel will generate a strong magnetic field. Radio waves of different frequencies are projected at the head, and from there the signals are generated into brain images. The functional magnetic resonance imaging, or fMRI, is a functional brain imaging diagnostic tool that provides more detailed 3D images of brain structures and activities by aiming a powerful magnetic field at the body. Images show which regions of the brain are active during a specific mental activity. For example, initiating actions, experiencing feelings, solving verbal riddles, or visual puzzles. BEAM, or Electrical Brain Activity Mapping, is a functional brain imaging tool related to the EEG, which provides a visual interpretation of and the EEG brainwave readout. It provides a visual EEG interpretation that allows clinicians to see the areas of the brain that are active during any given activity. In the illustration on this slide, you can see the EEG brain electrical waves on the right and the corresponding visuals of the brain activity on the left. You can see from the images on the left that areas of brighter colors are active during the activity listed on each slide, indicated that they have a role in that specific function. For example, number 1 is a snapshot of brain activity at rest. Number 2, of while the person is viewing motions. Number 3, while the person is listening to words. And number 4, while the person is speaking. In each instance, you have different areas of the brain lit up, representing the areas that are strongly functioning at that point in time. The magnetoencephalography, or the MEG, is a functional imaging tool that measures electrical brain impulses or brain activity in real time. In some cases, MEG can pinpoint the source of an epileptic seizure much more accurately than the traditional methods of EEG. The short video linked on this slide is also linked on your Blackboard site immediately under this video lecture. It is a short 46-second animation of how an MEG works. Take a few minutes before starting the next video lecture to take a look at this amazing technology that allows us to look inside the brain and see it working in real time. And that brings us to the end of our first video lecture for this week, Lecture 2A. Be sure to go back to Blackboard to view the short video demonstration of the MEG, and then on to Part 2 for this week's module, Lecture 2B. See you soon!